Many thanks for inviting me to this lovely meeting. I have nothing to discuss, and I will invite you for a short but very exciting trip, lasting about 15 minutes, no longer. The start point is based on some facts. During the journey, we will find some suggestion, and nobody knows where is the finish line, because we will find relevant doubts and unresolved questions. So, as Dr. Cristina Maggi tells us, huge effort has been made in order to ascertain the best, to select the best. Thank you. Oh, thanks. Thanks. We have been using morphological criteria. We have been using metabolomics, otheromics, time lapse, etc. But today, we are far from an accurate method for predicting the real capability of the embryo for a successful implantation. For instance, here we can see lovely and perfect blastocyst, but they aren't of any value if the embryos are carriers of chromosomal abnormalities. This first fact goes to the second fact. You know, all of us realize that there is a trend of delaying parenthood. It means advanced maternal age, and advanced maternal age means high rate of aneuploidy. The clock is ticking. You know that the rate of aneuploidy, the rate of miscarriage increase day by day, and live birth decrease. And in conclusion, the success rate on IVF treatment decrease with the age of the women. So, and this give us to the third fact. Patients are very demanding. Patients demanding positive outcomes as quick as possible, shortening the time for pregnancy, open a strong competence between clinics. Despite there is not any universal agreement of using PES. For instance, nowadays in USA, the vast majority of centers perform PES as a routine for all the IVF treatment. So it seems that PES is of clinical value. In the recent years, a huge amount of publications focused in this topic shows that it works. Now, Cristina tells us as well some recent results. So, and furthermore, implantation rates after transfer of euploided embryo are independent of maternal age. So, when we perform very carefully an embryo biopsy, after taking a few trophoblastic cells, using sophisticated technology like laser, etc., and when Array platform arrived, we were more than happy when we finally had a method for performing a comprehensive chromosome screening in a very quick way, less than 24 hours, and technology optimized for single cells. And if we were happy when microarrays arrived, we were more than happy when next generation sequencing arrived. But next generation sequencing as well bring us more doubts about what can we do with mosaic embryos. In this recent paper, comparing the result of microarray versus NGS technology, we see that the implantation rate was higher. The live birth rate, the ongoing pregnancy rate is higher as well in the NGS group, and we have more biochemical pregnancies when we compare the array group with the NGS group. The spontaneous abortion rate is similar, and conclusion is very simple. Next generation sequencing has the ability to identify and screen for embryos with reduced viability, such as mosaic embryos. And furthermore, embryos carrying of chromosome abnormalities could be remain detected by current method like arrays. such as low-level mosaicism. And we have unresolved questions. First of all, what about the mosaicism? Second question, the current state of knowledge. And finally, the clinical decision and the relevance of our clinical decision. Briefly, mosaicism is defined as the presence of two or more populations of cells with different genotypes in the same embryo, and is a result from mitotic errors. It's estimated, but between 20 and 30%, some papers publish a high rate of mosaicism, around 40%, and to date, the distribution of mosaicism in human embryos is unknown. Mosaicism can affect euploid embryos in any of the chromosomes. Here we have several examples. And as well, mosaicism could be present in aneuploided embryos or chaotic embryos. If we compare the same sample, comparing RI and comparing NES, we can see that we can detect in more details the loss of chromosomal material. When we have a meiotic error, we have an uniform aneuploid embryo, no discussion. The problem is when, during the first stage of human embryos cleavage, one mitotic error appears, creating different population of cells, and consequently, we are facing with mosaic embryos. And it's important to pay attention that when we take the sample, we are taking samples of trophoblastic cells. And we have several possibilities of different combinations. We can have abnormal cells and the trophoblastic cells in the external cell mass with a normal inner cell mass. We can have another combinations, and we assume that trophoblastic biopsy represents, it's a mirror, the rest of the embryo. But we have another open questions. First of all, our embryo is able for eliminating aneuploided cells? Second question, are they excluded for the future baby? And finally, do they contribute to fetus and placenta? Oh. To date, we have a paucity of data. It's a scarce evidence. Few studies, observational studies, has been published, and they agree that the mosaic embryos implant less frequently and are associated with higher miscarriage rate when we compare with embryos having a set of chromosomes completely normal. And we have, as clinicians, we have three possibilities when we have a result of most embryos suffering from mosaicism. First option is regard all these embryos as abnormal and discard them. The second option is blind our eyes and disregard the mosaicism and transfer the embryo. And finally, when it's possible, prioritize mosaic embryo for transfer based on the best information currently available. But the current information available is not very high. We have a paucity of data. This is, from my knowledge, this is the first paper published by an Italian group 2 years ago, in which they study the chromosomal status of embryos carrier of single mosaicism with normal babies. Very soon, other papers published for a group of Elpida, Grufogroli, Santiago Munet, show similar results. And in order to clarify this issue, we carry out a study in which we reanalyze mosaic embryos not detected with microarray. We compare transfer of the outcome of transfer of euploid mosaic embryos versus transfer of fully euploid embryos. We reanalyze the results of 1,362 biopsies at blastocyst stage in 473 cycles. The indication were advanced maternal age, abnormal sperm fish, and recurrent miscarriage or repeat implantation failure. In this group, we obtained 50% of the embryos were euploids, 32% aneuploids, and 30% were carriers of some degree of mosaicism. What's happened? From this group, when the mosaicism affects aneuploid embryos, discard the embryos, of course, but what happened when we transfer a 54 euploid mosaic embryo? Well, we only observe that the clinical pregnancy rate is lower when we compare when the embryo is carrier of that single mosaicism or is carrier of two or more mosaicism. We don't observe any differences between groups. And according to the outcome of the offspring, all the babies born show normal karyotype. 3 of them were not prenatal karyotype, was after the birth of the baby, but all of them show normal set of chromosomes. So, in summary, we can summarize that when the embryo is completely euploid, probably the embryo will implant better. When the embryo is carrier of some degree of mosaicism, some implantation potential can be expected. And of course, when the embryo is aneuploid, there is a high risk of pregnancy loss or unsuccessful treatment. As a conclusion, according to the current data, we can conclude that mosaic embryos have a relatively good IVF success rate, should not necessarily be excluded, but should be given a lower priority for transfer than those that appear to be fully euploid. Pregnancies established after transfer of mosaic embryo should be subjected to prenatal testing to confirm the absence of aneuploidy in the fetus. And finally, we must give information to patients regarding the outcome of the cycle and the genetic counseling in case of ongoing pregnancy. I would like to give thanks to the Instituto Bernabeu Biotech team, especially Dr. Ruth Morales, and thank you very much for your attention. Thanks.
Before to